Apologies for the slight delay. We have had a little bit of an alarm system go off here at the council chamber, so we are a few minutes late. We've had a number of apologies from a number of councillors.
Yeah, apologies from Councillor Repton, Councillor Hudson and Councillor Mulhall.
Okay. We've got all the most important people here, so we'll continue as we are. And so if it's okay with everybody, we'll go around the room just to do introductions. For those that haven't met myself, I'm Nicola Ralston. I'm the chair of the Adults and Health and Scrutiny Review Board. I'm also a councillor for Spondon Ward, along with many other hats that I put on and off throughout many different days. So I'll go to my left, we'll introduce the councillors, and then if you could introduce yourselves, that would be fantastic. Thank you.
Thank you. Councillor Kirk Cosby, Vice Chair of this board, and a councillor for Alveston North.
Councillor Carmel Ashby, councillor for Abbey Ward.
Councillor Jangir Khan, councillor for Normanton Ward.
Good evening, everyone. My name is James Lewis, and I work for the Joint Strategic Commissioning Team for Learning Disabilities and Autism at Derby and Derbyshire Integrated Care Board.
Good evening, I'm Alan Reid. I'm a consultant in public health here at Derby City Council.
Good evening, I'm Saurabh Pandey and I'm a GP. I'm also the clinical lead for the Integrated Care Board in Derby and Derbyshire.
Hello everybody, my name's Bess Fletcher. I'm an engagement manager from the Integrated Care Board.
Hello, I'm Scott Webster. I'm the Head of Programme Management, Design, Quality and Assurance at Derby and Derbyshire ICB.
Perfect. Thank you everybody for the introductions there. I'm not aware of any late items for this evening's meeting, and have we got any declarations of interest from the floor? No? Perfect. So we've got minutes held from the previous meeting on the 16th of April 2024. Are we happy with those minutes? Anything to be noted? I have a proposer and seconder. I'll propose them. Seconded, Councillor Ashby, thank you. And so our fifth item on our agenda this evening is our autism and comorbidity disorders, and that's being taken by yourself. Fantastic, thank you.
Yeah, good evening, everyone. Scrutiny may remember that I attended with Dr. Charmian Round earlier in the year to talk about the autism diagnostic pathway, and I suppose this presentation falls nicely following after that. I just wanted to thank the Scrutiny Commission again for the interest in autism and the spotlight that it's helping to shine on autism, because it is, you know, in the world of health and social care, it can often become, when you're working alongside acute pathways in big hospitals, sometimes topics like this don't get as much light shown on them. So yeah, thank you again for asking us to come and talk about this important topic. So there's been a paper been submitted. We've put together a bit of a summary presentation for those people who haven't had a chance to read the paper or might be watching live, which we're planning on going through. I'll start, hand over to Alan and Saurabh, and then I will conclude, and then lots of time for questions and comments, if that sounds okay. Next slide, please. So this is a slide that we've shared with Scrutiny previously. It summarises and looks to define what autism is, but effectively, autism is a spectrum of conditions which largely fall into the category of neurodivergence, which effectively means that autistic people experience the world in a very different way from people who might otherwise be described as neurotypical. Some of the ways that it affects autistic people can be things like difficulties in developing and maintaining social relationships. It can be in sensory processing, so either oversensitivity or undersensitivity to light, sound, touch and things like that. And one of the ways that people can most associate with autism is things like autistic breakdown or spiraling, where becoming fixated on something and it decreasing into what is called an autistic meltdown. I certainly will be referring to autistic people as autistic people rather than people with autism. That's just the majority preference of the local autistic community. Lots of people say people with autism, autistics. The important thing just to remember is to treat everybody how they want to be treated ultimately, and use the labels that they best align to. Next slide, and I'm going to be handing over to Alan, but I'll see you in the bend in a little bit.
Thanks, James. So when we're talking about comorbidity, it's best to give a bit of a background to that. That refers to the presence of 2 or more additional conditions alongside the primary diagnosis of autism. And in the case of autism, comorbidities are not uncommon. In fact, they're the norm rather than the exception, with research showing that more than 70% of people with a diagnosis of autism have at least one co-occurring condition, and approximately 40% estimated number of autistic people actually have 2 or more comorbid conditions. So it is a really significant area to look at. And just alongside that, we've got some of the general prevalence to give you an idea of numbers who may be affected by autism and the associated comorbidities. So we've got an estimated prevalence of 2%, 1 to 2%. Actually, we know from studies that there's a lot of undiagnosed autism in society, so we know that's an underestimate. How that translates into figures for Derby and Derbyshire, we've got 9,300 autistic children across the whole ICB footprint, 2,360 adults diagnosed with autism. And again, as I stress, we know that is likely to be quite a considerable underestimate for that as well. So we move on to the next slide. Going to go through some of the main comorbidities and by terms of their grouping, and one of the most common ones is mental ill health associated with a diagnosis of autism. And you can see that particularly associated with anxiety disorders, up to about half of people with an autism diagnosis report having anxiety or are diagnosed with that. And that increases with age, particularly into adolescence and into young adults, and then through into adult life. Depression as well, about a third of people with autism will have comorbid depression as well. Again, adults particularly vulnerable, and that's related to the awareness of the impact of society and societal pressures on the condition. So potential impacts, disrupted daily function, increasing social isolation or loneliness. I'm going to pass over to Dr. Saurabh Pandey, who to give us a clinical picture of mental health with autism.
Yeah, thanks, Alan. I think the clinician point of view that I'm here to try and present is that it's not easy sometimes to tell whether someone in distress with emotional and behavioural difficulties whether it's due to the neurodiverse condition such as autism, or whether it's due to a coexistent mental health problem such as depression, anxiety being even more common. So it can be quite challenging from a clinician point of view, and one has to keep an open mind and not assume that everything that is going on is due to the autism. There's a term we use called diagnostic overshadowing, which is when once you've given a person a diagnosis such as autism, then everything that happens gets attributed to that diagnosis. And it distracts you from the fact that other things might also be going on, and of course that can lead to unmet needs and poor outcomes. So it's very important we take that open view and sometimes use the benefit of other specialists and other skill sets within the NHS to help us tease out what's really going on. The earlier the diagnosis, the better. The earlier the intervention, the better. So the longer you leave somebody with unmet needs, the worse the outcomes can be. So I thought that was important to emphasise.
Just in terms of prevention, I think it's important to recognise that prevention in its broadest sense can apply to any stage of the disease or condition process. So we've got primary prevention where related to where a condition or comorbidity can be entirely prevented, but actually the secondary and tertiary prevention where preventative efforts can mitigate or reduce the impact, not just for the person with autism, but also, perhaps more importantly, their care circle, their family, and those who look after them as well, which is that significant as well. So for mental ill health and autism, obviously early diagnosis, as Sorab has said, is key, but also targeted behavioural communication and therapies in terms of psychological based therapies, and then environmental factors and in terms of parental involvement and support. So really emphasising the role of voluntary community sector there to support and peer support mental ill health. Can we go on to the next slide, please? Another common comorbidity is neurodevelopmental conditions with autism, and that includes learning or intellectual disabilities, where about a third to about a half of people with a diagnosis of autism are estimated to have. Epilepsy as well as a common one, that fifth to about a third, 20 to 30% of people with a diagnosis of autism will have occurring epilepsy. Sleep disorders are particularly common, and that is again probably related to anxiety and depression aspects, with about 50 to 80% of children especially having concomitant sleep disorders with autism, and also related to other neurodiverse conditions such as ADHD. And these neurodevelopmental conditions really do exacerbate the main symptoms of autism, such as irritability, difficulty in focusing, and the effect on social relationships. And so really that's why the management of autism with the neurodevelopmental conditions require that specialist multidisciplinary care and oversight, which James will pick up later in the presentation. Thinking about the preventative interventions for that, this medical intervention in terms of drugs and medicines for that, but also establishing good sleep hygiene and then psychological support with that. Next slide, please. Another growing area of interest and possibly concern as well is and well known amongst people with autism and their family and carers, is the associated gastrointestinal conditions that go with that. And in terms of the prevention of that, we're limited here because there's certainly a strong genetic component that's still being developed in terms of what works alongside or perhaps as a factor in driving autism along with gastrointestinal. But we know that constant constipation, chronic constipation, diarrhea and abdominal pain, it's quite a wide range, but certainly up to a third to up to 70% of autistic children that will be reported. And linked to the autism and perhaps set of behaviours, food sensitivities and restricted eating behaviours can actually cause a big impact on nutrition and the effects of ill health related to that. So that can really affect quality of life. It can exacerbate behavioural issues if there's malnutrition and not getting enough food, obesity if there's overeating as well, and conditions like PICO where they can be eating non-nutritious foods, those non-foodstuffs. And again, the diagnostic challenges in gastrointestinal are not still being developed, not well understood. It could be related, as I said, genetic, gut microbiome, or neurological factors that are playing a part. But preventative interventions, so dietary intervention, working alongside specialists, looking at reviewing medications or alternative interventions, and obviously being linked to health eating and lifestyle services that we refer, making sure that they're autism friendly. Next slide, please. Other conditions, of course, include perhaps obesity, sensory sensitivities, processing difficulties, very common. Maybe other sort of comorbidities that are less well understood, like immune system aspects or other sensory conditions as well. But these are less understood. Next slide, please. I'll just go on, we'll just take that slide back and I'll let Sorab just come in just a little bit if you want to just finish on these.
Yeah, just to mention on the constipation and gastrointestinal aspect, autism as well as learning disabilities, it can be very, very seriously life-threatening even in some patients. So these are not trivial issues. It does sound when you just say the words like constipation, but actually these are really quite serious issues that can lead to hospitalisation and life-threatening. And I think that one aspect that I ought to bring in, because I am clinical, is the medication. So medication that we use in patients with mental illness particularly, of which this is a common part in some of the patients, as we've seen, can lead to obesity and diabetes and other side effects. So we have a job as clinicians to make sure that we're not making somebody worse rather than better. It's not a simple matter of putting someone on medication and forgetting about it. You really do have to keep a very close eye on their physical health as well. And that's why we have annual health checks.
Next slide, please.
Yeah, and just before I go into this, Sorab picks up the point about constipation. These are all things that significantly reduce quality of life. And if looking at sleep issues affecting 80 to 90% of autistic people, we all know what it's like to not have a very good night's sleep. We'll stretch that over weeks and months. That's the kind of, so these are really serious things that do affect quality of life, and all those comorbid conditions all playing into each other, can really disrupt somebody's experience. In terms of services, so I'm going to focus initially on what the kind of specialist offer is for autistic people, and then I'm going to comment on the wider service pathways in a second. So we in Derbyshire for about 3 years now have had we've had a specialist autism team which provides support for autistic people who are at risk of significant harm to themselves or others. So this might be people who are experiencing, suicide ideation and the proclivity to self-harm. It might be people who are at risk of mental health, in hospital inpatient admission, or it might be somebody who's getting 24/7 support where that support is going to break down. And that specialist autism team is a multidisciplinary team with occupational therapy, psychology, speech and language therapy, all inputting, and it works alongside the social care, community services as required. And as of around last year, we've also commissioned what is known as the short-term intervention team, which is a voluntary community sector which provides hands-on support for people in the community, particularly those who are experiencing things like suicide ideation. And it's about having, as much as anything, a friend to go and speak to somebody and provide them with a bit of hope and a bit of comfort that, they'll get through these things. And it's had some real successes, and we're hoping to continue with that service long term. But in terms of what this team means, we've included a snapshot of the comorbidities that they've been working alongside. You'll see that it's predominantly within that mental health space. And that is aligned to what the team has been set up to do. Naturally, they will interface with those other comorbidities as part of their work, but that main area that they're driving towards is that mental health comorbidity. Next slide, please. And then previously, when we come to Scrutiny, we've talked about some of the other voluntary and community sector services that might be available for people, such as, most recently the neurodevelopmental hubs, which provides an opportunity for autistic people, whether diagnosed or undiagnosed, to come to a place where they will be welcomed, where they can receive some, general support, but also be signposted to universal or other services which might meet some of those comorbidities that we've just talked about. Next slide, please. So suppose you kind of wanted to land some key messages just to finish off. So clearly comorbidities in autism is really important, and we've kind of highlighted 3 reasons why. The first is that it complicates the diagnostic process significantly, and as Sorab talked about, it's a diagnostic overshadowing. In the field of learning disabilities, it kills people. And in autism, it could well do the same as well in terms of that interface between mental ill health, autism, and other conditions. these comorbidities exacerbate the challenges faced by autistic people. So to give an example, an antipsychotic you might get to help treat a mental illness might then cause you to gain weight and obesity. So, you know, it challenges multidisciplinary teams and clinicians as to what is the right course for that person at that right moment and what is the right response over the long term. And then finally, development of effective interventions requires us to understand more about comorbidity. So, you know, particularly in that field around gastrointestinal, clearly there's more research to do. And then kind of finally, in terms of where we're at and the future, autism is generally not well understood still, and we as a society and as a, you know, a field of in health and social care still have a long way to go before we really truly understand even the causes of autism, but also how it can be effectively, how we can effectively support people, how we can treat associated comorbidities, etc. Even though some of those morbidities are potentially genetic, a lot of them can be prevented by good universal community secondary care services. And I suppose my work particularly is aligned to that mental ill health space. We know that having a more inclusive society and things like that will improve the quality of life that people have and people's mental health and well-being. And those are some of the comorbidities that can be prevented if we, you know, design services to meet the people's needs. And lastly, and probably most importantly, most of the care of autism comorbidities sits outside of specialist autism teams. So, you know, I can talk fairly confidently around the specialist autism team, the wider VCSE offer, but, you know, actually what this is really about is upskilling other services so that they can appropriately treat autistic people and make sure that those specialist autism services know when to recognise, when to refer people on to those other pathways. And as Scrutiny will probably know from previous times that I've presented, those services need to be adjusted to meet the needs of autistic people. There's lots of fairly simple ways that that can be done, like double appointment times in general practice, allowing somebody who's autistic to experience a ward environment or a clinic environment before their appointment, allowing people to bring people with them. But there's still barriers to access that, you know, we need to get a little bit better at in the NHS and wider services as well. I hope that's been informative and has answered some of the questions that you might have beforehand. But yeah, thanks again, and yeah, happy to receive any questions or comments.
Thank you. I'm going to open to the floor first, if there's any questions or comments from the floor, from the councillors. Councillor Ashby.
Thanks. I'll probably say partly what you were going to say, Councillor Rolston. Firstly, thank you for the report. Very comprehensive and helpful to have in advance. I was interested to read about the potential for preventative care with early intervention. And you won't be surprised to hear me say that that's where my concern is, therefore. With the huge delays in diagnosis, whether we're looking at children or adults, it's really going to scupper, and is presumably well, you know, for many years, scuppering the ability for early interventions. You know, it's really good to hear about the specialist team, but that's obviously for the people at the very high level of need, where that's not where the majority of people are, I presume and believe. So it's what we can do to make use of the fact that we know the preventative measures can be effective. But that said, I'm sure you don't have, I'm sure we come back to funding and staffing and all of that. But thank you very much for the information.
Thank you. I think you're making a very, very valid point. So thank you. The challenge with any service which is specialist is to sort of get the balance right between the specialist service versus what's going on in the general services. So both are needed. We certainly are doing very well in some ways on the specialist services. We are doing more as much as we can, I think. But what we ought to be also looking at is how to empower the general services, for example, normal services for diabetes or asthma and chronic obstructive airways disease. How much are they supported to be able to help those who have also got autism? To what extent are we empowering that is something we should potentially look at, I think, so that there is inclusiveness in all services where possible, if that's a helpful thought.
And just another aspect of that, in terms of the support with the voluntary community services there, when someone, a child or adult, initially gets a diagnosis of autism, an opportunity at that point would be to have that wraparound service for awareness of comorbidities and any preventative interventions that could be done at that level. That, and notwithstanding clinical things, but aspects, but certainly, supportive, psychological interventions, social interventions that can help. And I think, our voluntary services that we have for autism are geared up to that and are aware. It's just about making sure that they're more artistic friendly as they go into to standard services there for the wider population, that they're artistic friendly.
And I'd conclude by saying that, we've made it a real mission that the services that we commission for autistic people do not require a formal diagnosis. As long as it's suspected, you can access the specialist autism team, you can access a lot of our, in fact, I'm pretty sure it's all of our BCSE commissioned service offers, recognising that there is a long waiting list for people. It's not going to completely eradicate the problem that you talked about, but at least it will help those who most need it.
Thank you. There's been some really, really interesting points today, and there's a lot of things that have come out of the presentation that I'm interested to sort of pick up on going forward. One of them was starting with the numbers. I think it was something like 9,000 children and only 2,000 adults. And I think, sorry, is it?
It's the wrong way around. I forgot to mention it. Yeah,
Oh, okay,
that's
excellent.
my fault. Moving slides over from one side to another, it was my fault. Those figures are actually the other way around.
That's even better, because I was going to suggest that maybe that was mainly down to diagnosis and knowledge and experience of, and it wouldn't have surprised me, in all honesty. Just to put into context my understanding of autism, I live in a very neurodiverse household. I have everything from autism, ADHD, gastro issues, from sensory processing disorders, dyspraxia, dyslexia. We have a very varied household. And actually, knowing what I know after living with my family for the last my eldest is 17 now, this knowledge is not something that is there, and it doesn't come in the parent guidebook. And over the years, that knowledge is built up, and I, obviously, from an experience point of view, all of the things that you've mentioned today, it's there for me is in black and white. But obviously, from a perspective of people who have no knowledge of autism and not understanding all of those things, it was interesting you said about things going under the radar because of that diagnosis. And actually, I think we've certainly in children's, we've pushed for that, not a need for diagnostic, because, as you say, the help just needs to be there. And schools are becoming more aware of that. The educational healthcare plans side of things, it's coming away from we need labels. The point is that the support needs to be there, as opposed to and don't get me wrong, we live in a society where unfortunately we do need those labels to get the support. And ideally it would be a situation where actually that support is available, as you've said, for a lot of our services now, which is really good to hear. Because it wasn't the case a few years back, and I think it's a good move from us as a city, that it shows that those things are coming out there. Just overall, it's a really positive thing to be hearing the knowledge and experience that we're gaining, and obviously that is forever. The experience will come and grow, but it's from our perspective what more we can do as a scrutiny board to try and get that knowledge. That the slide that had all the information out there, and of what is available for Derby residents. I think that is a really key slide, because there's things on there that I wasn't aware of as somebody in a family with adults and children from all generations. So promoting that as a city council and as a board, if that's something we can help to do, then we would really be keen to do that.
Can I just come in there and just flag up the Derby and Derbyshire emotional wellbeing web pages? It has a really comprehensive section for autism with available resources. So I'll cross-reference what's on there with James's slide for that, and just to make sure that that information is up to date. But yeah, just for anyone watching, for yourself, for anyone in the room, just to flag that up. So it's Derby and Derbyshire emotional wellbeing pages, and it has all the resources for across the range of mental health, learning disability, and autism services.
That's great, because I noticed that obviously with those that are diagnosed early, so those that are diagnosed in their youth who do have an educational healthcare plan are supported up to 25 within that sort of educational healthcare plan system. But it's those adults that we are now, and you mentioned about doctor's appointments and things. Now, like many, I'm sure, going to the doctors would be quite a significant challenge for a number of people on the autism spectrum for various reasons. And I know myself, I don't think my son's been since he was first initially diagnosed. And I think for me, it's a bit, you mentioned asthma. I'm asthmatic and I go to my reviews every year. There isn't that review every year. There isn't that support for somebody who just touching base with their doctors, or and it's something that I think as part of the NHS, part of doctor surgeries, I think they should be hopefully promoting in terms of access to doctors and maybe having that touch base annually, biannually, as to where things are at, so that these comorbidity disorders don't go unnoticed.
Hi, yeah. No, that's a really good point about GP appointments, for example. Can I mention just two things? One, which supports really what you've just said, actually. One is that the importance of reasonable adjustments, we call them. I don't know why we call them that, but it's reasonable adjustments, which is whereby once the surgery has been made aware of what would support somebody to come to an appointment and to cope with that appointment easily. It might be that it's a 20-minute appointment instead of 10, or it might be the noise in the room they're helped to avoid. You know, all of those things can be put in place by the surgeries, and we've now got to the point where we have a digital flag, which we can, it's a national NHS England initiative whereby all surgeries can adopt a digital flag, which means that on the computer you will immediately know that that person needs reasonable adjustments and be able to put those in place to help them. So that's the first thing about trying to make practices more friendly, if you like, and accessible. The other bit about comorbidities and annual checks is a very good point, and we do a lot of work in Derbyshire to do annual health checks on people with learning disabilities and autism. So the health checks include a range of tests like blood pressure and cholesterol, and looking at lifestyle, and including screening questions about other health issues. So yeah, and we do quite well in terms of the percentages that we reach. We're doing well, I think. I can't give you the exact figure, but it's up there in the 80s or something.
So if I may ask on that front, and I will come back to you, so is that a common practice amongst GPs to invite individuals recognised with
yes.
autism?
Sorry.
That's absolutely fine, perfect. That's great to hear.
Yes, it's part of what's called a DES, isn't it? Do you want to come in on that?
Yeah, just clarify that the annual health checks are for people with a learning disability, which will include people who have a learning disability and autism. They are trialling autism only annual health checks in Newcastle with a provincial review of a rollout nationwide as well. So it's not available for autistic people without a learning disability yet, but the direction of travel is that it could be in the near future.
But I just want to add something to that because that was helpful. I'd forgotten that. But just say you have just got autism, but no learning disability, but you also have asthma. There's no reason why you shouldn't be invited for your asthma checks, but with reasonable adjustments attached, using the digital flag so that we know how to help you to make those appointments, if that makes sense.
Yeah, thank you. I raise it because I know that there will be people out there that are starting with that on those journeys of having mental health issues, other comorbidity disorders that haven't been flagged, and I do think it's an important part of that regularity. And I think if it's part of a routine, which is often really helpful for people on the spectrum, that if there is that opportunity to speak to somebody that they've got to know over time with for example, a GP, that those things may come to light and they'll be more preventable in the going forward. So, I mean, I for one would like to recommend writing to the NHS to support following something similar to the Newcastle model, to invite our young adults and adults to regular reviews. So I'm going to pass over to Councillor Ashby.
I was simply going to make the distinction that the current annual reviews are for people with learning disabilities. I suspect the NHS will want to wait for the outcome of the trial being done at Newcastle before they'll do anything, but I agree with you, it would be good. That's probably way down the line.
Yeah, I just wanted to ask about the city and the GPs, yeah, and how well are they sort of approaching autism in the city, and the community services you mentioned, some of the community services, the hubs, how well are they referred by who?
I think, so to answer specific questions on how individual GP practices are doing is going to be difficult for us to comment confidently on, just because obviously we oversee a huge number of primary care networks in around, and I would suggest that maybe that could be a good role for Scrutiny to do, to inquire as to local primary care networks as to what type of reasonable adjustments they might offer, alongside what SORAB said around double appointments. GP practices across the country are doing things like having sensory boxes in the practice so that people, fidget spinners were the rage a few years ago, but they can be really helpful for somebody who wants to who wants to self-stim while they're there and things like that. So yeah, unfortunately, I'm not going to be able to confidently comment on individual primary care services. What I would say in terms of the community services, the neurodevelopmental hubs get really good responses from people who use them. Yeah, okay, yeah, perfect. So they get really good responses most of the time from people who use them. Possibly that's because there hasn't been something like this before, particularly prominently. So it's just really great to have a service available for people. I drop in on the hubs every once in a while just to kind of talk to people, and everybody who I've seen there has got a really good personal response from the people who run the service. So they're a real benefit. In terms of the outlook and environment for the voluntary community sector at the moment in Derby, things are really tough. You'll have seen in the long paper that was presented, there's been challenges with one of our most prominent providers, Derbyshire Autism Services. There was a press release included in the paper pack. Real challenge that they're facing at the moment in terms of their financial sustainability. And we have to do all that we can as statutory partners to make sure that we have local services available for people. And, I called Daz earlier today just to get an update before Scrutiny. So we're keeping a real close eye on the long-term sustainability of that particular part of our health and social care economy, but things are tough at the moment and will probably continue to be tough for the next few years or so as the public sector faces, a significant financial challenge.
I think our thanks go to the voluntary sector. We know how much support that they give to our communities in general, but also specifically around this, because the experiences that people face are greatly improved by having those networks available to them. And I know that they can be well attended, but my concern is those that don't, and those that aren't aware of them or can't access them for various other reasons. And if we can fill those gaps in terms of support by getting those regular annual, biannual reviews for adults, I do think that we will see less of those high risk factors, sort of men with at risk of committing suicide and things like that. I think there's a lot of that goes missed because of the lack of ability to be able to access those facilities. And I think for me, if it can save one person, then it's something that we should, as a scrutiny board, make that suggestion to see if we can promote that as a best practice or as a ideological practice in Derby. Is that okay with everybody?
Yeah. And can I just come in and just highlight the Joined Up Care Derbyshire's autism strategy 23 to 28. Preventing illness and prevention is a key theme and focus of that, including suicide prevention linked into this. So it is there, in the strategy, and action will be ongoing during that.
So again, just a point of information, I was going to say that the Oliver McGowan training has been rolled out in general practice in Derby over the last 2 to 3 years, and I would expect that everybody apart from new recruits will have undergone that training in the last 2 to 3 years in general practice. And it's excellent training. It's really, really helpful and gives a great insight for people in general practice and helps them to understand the need for reasonable adjustment and all of that. And I think a lot of general practices, I think it would be really hard to get harden, you know, every practice has this, that or the other. But I think practices will be open to making the reasonable adjustments, the double appointments at the end of the day when it's quieter, those sorts of things. But again, it's the sort of thing you've probably been doing as a parent because you know, and that's what people will do is, you know, make those, you know, work with the practices to make the reasonable adjustments that will work for them as families, really. But it's not something that's easy to legislate for because the reasonable adjustment, as you know, depends on the individual.
And that's great. I'll come back to yourself, sir.
Yeah, just about the training. Yes, I agree entirely about the Oliver McGowan training. It's excellent. Everybody's meant to do that. I can't say how many have done it, but it's mandatory. So I imagine that everyone's done it. But the other aspect which has just been raised is the suicide risk is higher in the population of people with autism. And we are taking suicide prevention extremely seriously in Derbyshire and in Derby. And I'm pleased to announce that we have now a team of champions who are going out to GP surgeries across the whole patch to offer training to the primary care teams. And part of that will be to identify, you know, that autism is a particularly high risk group and how reasonable adjustments are needed to be able to help anybody with autism. It's not just simply a matter of doing the same thing as everybody else, as you might do with somebody else. So, you know, you have to involve carers. One of the things I'm most passionate about is involving those people who know the patient, or in this case a patient, but the person best, and not expecting the person to deal with everything on their own if they can't. So really it's about being patient-centred and sensitive to their needs and understanding what suicide prevention is all about, which is what the training's going to achieve, hopefully.
That's excellent news and really, really good to hear. Thank you for that. I think it's been really useful, tonight's meeting, and that presentation has really helped me to feel confident in the way that things are progressing and moving forward, and your knowledge has been very useful, so thank you very much for that. is there any other points or questions or anything to raise? I think we've made our... It'd be interesting to see if in the future we could come back to see how that Newcastle strategy or trial has gone, and if that's something that Derby is going to be interested in looking at going forward, because I do think it's, you know, we've from asthma to diabetes to everything else that has regular reviews. I think it's something that I personally think would prevent a lot of future issues for these young people and adults aside. Right, so if there's nothing else, we'll go on to our next item on the agenda. Thank you, gentlemen, for your feedback tonight. Our next item on the agenda is item 6, which is Derby and Derbyshire Stroke Rehabilitation Review. Can I ask that's yourself? Is it? Thank you very much, sir.
Hiya, thank you. There's no slides for us tonight, but we're going to provide an overview of the papers which have been presented. We've also got my colleague here, Beth Fletcher, from the engagement team, so if there's any questions on the engagement side of things, Beth will be able to take those questions at the end. So I'm going to present a paper on the Derby and Derbyshire Stroke Rehabilitation Service Review, looking at the case for change. In committee is asked to review and note the intended public and patient engagement and associated case for change with the service review. It is intended that the patient and public pre-engagement will commence mid-October. I think it's the 7th or 8th of October. So in terms of the pack itself, there was a couple of appendices attached. So Appendix A provides a very high-level case for change document. There is a more detailed document, about 20 pages long, which is on the platform itself. And the case for change spells out the key challenges and drivers for the service review. And I like to put those into 3 areas. So the first driver is around the services are at capacity, and there's an increase in patient demand. So since 21-22, there's been a 6% increase in admissions for stroke, which is having an impact on the rehabilitation services. In terms of waiting lists, something to keep an eye on as well. In terms of community specialist stroke rehabilitation services, waits can range between 5 to 17 weeks, and they can range depending where you reside within the county and the level of rehab support you need. The next key challenge is regarding current services are led by multiple providers, and there's a mismatch of services across the county. So fundamentally, there is no standardised pathway across the whole county. And then the final driver to talk about is the current service is not compliant with the National Integrated Community Stroke Service Model, which was launched in November 2022. So there was a benchmarking exercise which took place, which highlighted a number of areas where stroke services in Derbyshire fell short. But some of those updates are really, so just a high level we've put within the paper. So no team currently operates an integrated model. No service currently provides a full 7-day service, and no team provides a service on a needs-based model. So there's a number of areas there, but there's areas for improvement, I think it's fair to say. So in terms of driving the service review, we've established a task and finish group, which is made up of commissioners, clinicians, service providers and patient representatives. And the aim of that task and finish group is to drive forward these service options for the future. Like I say, we're very much at the start of the journey. Now, in terms of those service options, the expectation is that they would be in line with the national guidance, which has been launched, and they were the leaders behind the Case for Change document that you've seen, so they were the ones who developed that. So the second appendices within the document is around engagement. So there's an engagement plan, quite in-depth slides in there. So if I just give a bit of a high-level update, and I'm sure Beth will want to come in. So first and foremost, the engagement plan was not developed in isolation by the ICB. It was a holistic method has been taken when developing the engagement approach, and the views and opinions were valued from key stakeholders to develop the plan. So this includes input from patient representatives, carers, providers, Stroke Association, and the support charity Different Strokes, as well as the task and finish group. So lots of feedback feedback and input into that plan. So engagement activities will start in like mid-October and will be delivered in selected locations where the service offer varies. So as I said before about the variation. So in terms of public meetings, face-to-face public meetings, there is like meetings arranged in North Derbyshire, South Derbyshire, High Peak and Glossopdale. I'm also aware there's a further public meeting arranged for Amber Valley too. For those who can't attend those face-to-face sessions, there's also 2 live sessions online. So for people, South Derbyshire. Yeah. But we can provide more detail about where those sessions are. Beth can include those at the end. So in terms of those who can't meet during the face-to-face sessions, there will be 2 online sessions as well. Over and above the engagement workshops, there is also an engagement platform I mentioned. So there's an online platform which gives you more intel about the engagement plan, the case for change, and an opportunity to find out more information. There's an information and involvement flyer. There's a survey which is online. For those who don't want to do it online, I believe there's an option to send out a request as well. And then finally, there's some phone support. So why are we doing all this engagement? So fundamentally, we want to find out what currently works well and what could be improved with the current service and what is important to people for a future service. And all that feedback we'll receive will be used to influence those service options which will come forward at a later date. So the recommendation from the papers is to note the stroke rehabilitation service review, so we're at the start of the journey, but also to discuss them if there's any further suggestions in regards to the engagement plan. Thank you. If there's any further questions, myself and Beth will take them. Thank you.
Thank you. It's not one of our most positive reports that we've received here at the Adult Scrutiny Board. I think from myself there are a number of questions, but I'll open up to the floor first to see if there are anything that any councillors would like to ask. I'm going to go to Councillor Cuss first.
Hi, thank you for the report. I have a few questions. The first one is, what support is available for people who have had a TIA, which is a mini stroke, as 1 in 3 of these people are more likely to have a stroke in the future?
So in terms of the TIA, that's not currently in scope of the service review. In terms of that, as a non-clinician, I don't want to try and go through the detail in terms of we can provide that answer in terms of there at the moment. My understanding is that there is a follow-up, there's outpatients appointments at acutes, and there's also the support within general practice as well. But we can take that back as a query and we can provide that answer back at a later date.
Thank you.
Councillor Ashby.
You didn't even need for me to raise my hand. Thank you. And thanks for the report. I have a couple of questions. One is regarding time frame for the review you're about to do and the discussions, and when you hope to then have something on the ground. And do we have any idea why the rate of stroke in Derbyshire has increased, by 6% since COVID, and why the rate in Derbyshire is 2.3 as opposed to 1.8 across the country? Do we know anything on all of those?
So I'll take the first question first. So in terms of timescales, so the engagement period will take place over October and November time, my understanding. It is intended that we are looking to work up service options, which I expect will be coming back in January, February time. So what's happening at the moment is that good practice has been taken from across the country, but also making sure we align with national guidance with that. So we expect to report at the end of the financial year. In terms of implementation, it will be subject to the option which is taken forward, but the implementation we are hoping to commence in the year of 25-26, so from April onwards. So it's subject to that. So they're the timescales. In terms of the drivers for the increase in stroke, so there is a national trend which has taken place there. There's a number of factors which can lead to that. Lifestyle. So there's the lifestyle factors which are driving that, whether that's dietary, alcohol, etc. But also cardiovascular disease, so hypertension, atrial fibrillation in those areas. And we're doing to talk about the case filing element, we are looking at projects at the moment about identifying like members of the public who are hypertensive, are not aware of that, to obviously to support those case filings. But it's multifactorial, I think it's fair to say. In terms of the drivers, there's no evidence at the moment I can present you to say why in Derbyshire that has increased more than what it has in other areas, but it is a national trend.
Councillor Cuss.
Just following on the increase since 2021, what adjustments to resources and staffing levels have been put in place?
I think the honest answer there's been no changes in resource since the increase in demand, hence why we've got stretched services. So the reason, I mean, in terms of those challenges and drivers, they will all need to be taken into account as we develop and design the new model.
Thank you. So a couple of things you mentioned, the waiting list for support from times from anything from 5 to 17 weeks. It was quite shocking. So obviously we're Derby City, we're based in the city. It'd be interesting to know what our wait times are in the city itself, if you have that available. If not, if you could find that out for us. And obviously I appreciate that could be dependent on the severity of the stroke. The other thing that on one of your slides, slide 9, it mentions here the lack of resources in terms of there's no community stroke support team in the south, no psychologist support and no community psychology around this. And you mentioned we are south within the report itself. And again, that's quite a shock to me in terms of obviously tackling your health and the physical detrimental effect it has on you, the actual mental impact that having a stroke can have on individuals. Again, to get that positive mindset and to do all that is quite shocking. So in terms of I presume that this is part of those reviews to make that more accessible in all areas and not specifically in any one area. And how do you go about that really in terms of, you know, in the city we're a small area, so it should be more accessible, you would think, as opposed to the peaks and various other areas where you could potentially understand why it's not on the doorstep. But as a city, I would hope that those support things are available.
Yep, so if I take the first question, so regarding the weights, the 5 to 17 week range between services, so that varies from area to area and the level of rehab or the type of rehab requirement. I believe there is some intel and further data in the more detailed case for change, which will provide some of that information. If it's not, we'll have to get that directly from the service provider, which is DCHS within the community, but we can get that information if it's not within the case for change. And then the second question, obviously, about psychology and some of the gaps on the current pathway. So currently within Derbyshire, we don't have a multidisciplinary team for stroke. So stroke services can access mental health services, can access psychology services, but they're not embedded. And the need for an integrated community service will see that more embedment of the services across, because fundamentally having a stroke is a significant event, and the impact that can have on an individual is significant. So it is a gap, and I think psychology is one of the biggest gaps, which will be one of the first things which we'll want to resolve as part of the new model.
Thank you. Are there any other questions? Councillor Ashby and then Councillor Cush, thank you.
It's not so much a question, just a comment. I'm absolutely shocked that there isn't a comprehensive stroke service. I actually thought there was. And I'm deeply shocked to discover there isn't. Has there never been a more comprehensive stroke service? Or was there one that has ended for some
Yeah,
reason.
so in terms of, there are certain different elements to rehabilitation, so that's the scope of the work. So we've got early supported discharge. So in the north of the county, early supported discharge is led by Chesterfield Royal Hospital. So following a stroke, they will follow the patients into the community. In the very high peak, because a number of patients probably won't access a Derbyshire acute setting, they may go to Stepping Hill in Stockport, or they may go over the border. So that early supported discharge will be provided by a cross-border team. So obviously we've got a gap there, so we don't do early supported discharge in the far north. And now for Derby City, the early supported discharge is provided by DCHS. So it's a slightly different model whereby UHDB, so University Hospital Derby Burton, don't follow the patient, that's handed over, so the community team pick up the early supported discharge. So that's for minor to moderate. So we've got early supported discharge coverage, which is good, and it's evidence-based. The next element then is for the more moderate to severe strokes. So for those patients that don't meet the criteria for early supported discharge, that's where you're getting the 5 to 17 week wait. So that means about what type of rehabilitation needs they may need. So it may be OT, it may be speech and language therapy. There could be lots of reasons where they go. But the issue we've got at the moment is, so all community stroke rehabilitation is provided by DCHS, but the level of weights could be different in different parts of the county depending on where that hub is. So that's where the integration falls down. So what the new model will look to do is talk about one service which encompasses early supported discharge, encompasses community stroke rehabilitation, but also provides support for those patients who's not got any severe rehabilitation needs, because of the psychology impacts what they may have though. So it's about ensuring, and it doesn't say this in the paper, but the main driver of the new national model is to ensure that every patient that has a stroke is offered a service. So that is where we want to go. And being open, historic commissioning over a number of years has got us to the position we are now. So we need to bring that together so we've got one service for Derby and Derbyshire.
Thank you. You mentioned the moderate to severe, and that's where the waiting times are particularly higher. Are they therefore not being released from hospital, or are they being released home but without the support? So whether is that having a pressure on the availability of beds, or pressures on hospitals because they are having to stay in hospital longer or in supported care home facilities until they're able to be supported enough to get into their own homes? Or is this just a case of they are being sent home and therefore just being, not being supported at all? That's my concern really on that front.
So in terms of getting a full answer, I think we need DCHS to be able to provide that intel in terms of the exact pressures in terms of the process. But some patients may get discharged home, or some patients are waiting in a hospital. I think there's a fair assumption that it could be a bit of both. But I think for me to give a full answer there, I think we need somebody there from DCHS, the service provider, who could give more detail behind those service ways.
Yeah, I think that'd be interesting for us as a scrutiny committee to ask for that update really on what impact that this is having on our city hospital and the availability of beds and so forth. So if we could ask for that at a future meeting as part of our review for our agenda items. Thank you. Are there any other questions? Councillor Cuss, thank you.
Thank you. I was just wondering, why is early support stroke discharge not available across all regions, and does this have an impact on patients' outcome?
Yep, so in Derbyshire itself, all patients that go into a Derbyshire hospital setting will receive early supported discharge if they qualify for the criteria. We've just got those gaps in the county whereby patients who reside live close to hospitals outside of Derbyshire. So patients in Glossop or patients in the High Peak because obviously time is all important on the stroke pathway. They will be conveyed to a hospital outside of Derbyshire, which will be Greater Manchester area. So they will then join the early supported discharge pathway of those hospital settings.
Thank you. I think that's all questions for this evening. Thank you very much for the presentation and the very detailed report. Not the best we've seen, but in terms of it's a very good report, but not as a positive outlook for Derby City itself or for Derbyshire. So we've got a little bit more input from Beth. Thank you.
Yeah, I just wanted to obviously I've been leading on the engagement on this, and we've rarely worked closely with lots of different people who've either experienced a stroke, themselves, patient representatives or the Stroke Association, Derbyshire carers, and there's obviously if somebody's had a stroke, there's often communication or cognitive impairments that people might have. So we've worked really closely with all of those people who know how to communicate really well, to develop communication, the engagement materials. So we're really trying to reach as many people as possible with this engagement to understand what people's experiences are, what matters to them in a future service, and that will all be put into the development options at the next stages. So we're hoping to get all of our people within Derby and Derbyshire to feed into this, so that we can really make sure that their voice is being heard throughout it as well.
That's great to hear, thank you. And I think if there are opportunities to feed into that from a Derby City perspective, these, whether there are the technologies out there that, you know, whether communication skills wise, if there are things that we can sort of help promote or support or anything like that, please keep us posted. Councillor Khan.
See the engagement you mentioned in the city in the south. So the location, is it going to be online? Most of it, is it going to be face-to-face or workshops, or where would the location be in the city? So you.
Yeah, so we've looked at lots of different locations. We've worked a lot with Stroke Association because they have lots.
Could you pop your mic on for us?
Sorry, I forget. Yeah, we've looked at the kind of the geography of the whole county, and we've tried to pick places where we know people can access well as well. So we've worked a little bit with the Stroke Association about the buildings that they tend to use as well for their meetings. So there is one in Derby City that's going ahead, and then we're doing one in Amber Valley, Chesterfield, Glossopdale, and I think Matlock for the High Peak area. And then we're doing 2 online events for people who would prefer that method as well. And then there's also a survey. And then we've also worked with the Stroke Association and Derbyshire carers around sending out a flyer to people who would prefer postal access as well, to make sure they're aware of what's going on, how to get involved. And then we've also made sure we've got phone support, so if people might not be able to log on to the events online, fill out the survey, so there's always that method that they could join in. So we've really tried to consider every possible way so that people can have access to the material about the information, but also access the events to get involved as well.
So is the NHS writing to people to inform them of this, or is it something that needs to be promoted by us as a council to get the awareness out?
Well, what we've done, we've got a communication plan all put together where we've got all the key stakeholders across the city and the county. But the thing that we're sending out to the Stroke Association and the carers is a flyer that we've developed with them, so people who might not have digital access can still be informed by what's going on. So it's basically one piece of an A4 saying this review's happening, this is how you can get involved, and these are our contact details, you know, and giving them all that information if they need it. And what our comms lead is doing is getting a pack together of social media posts, posters, the flyer, and all the different ways, and sending it out to those key stakeholders so they can choose what's the most appropriate for their audience and then send it out. So they will be sending things to the council's communication teams, all the providers' communications teams, loads of community groups. So we've got hopefully a really good stakeholder mapping that will be sending things out to everybody so they can pick what's best for their audience.
Great, that's perfect. Thank you very much for that. Anything else, Councillor Ashby?
So once you've done the review and you've got the answers and the plans, is there going to be funding to do it? Because presumably, to improve what's currently being done is going to cost more than is currently being spent, because that's the nature of life in general. So are you just hoping to rehash the funding that's currently there, or will there be funding for what is required?
So in terms of the funding, we are working on the project with no additional funding at the moment. So this will be about utilising the funding we've got on stroke rehabilitation across the different service providers, and to utilise that funding to develop that one service where we want to go forward. We've not got into the detail yet into what current workforce models could look like, current increases in terms of staffing. But that will all need to be considered as part of the review. And no doubt when we look at the options, we will need to consider whether the current investment and resource we already have within the county would be sufficient for one service model, or do we have to look at a more phased approach?
In the document, it said that there are insufficient stroke doctors and staff for caring for people who've had acutely post-stroke. Is that because of lack of success in recruitment, or simply, again, lack of funding? Do you know?
So in terms of the consultant workforce, who won't touch as much on the rehab pathway, to be more AHPs, Alliance, so that is once again a national issue. So in terms of the consultant workforce, like nationally, there is a recruitment issue. So it's not just an issue for Derbyshire, it's an issue cross-border. But obviously...
So are there vacant posts then, or is it because we can't afford to employ enough stroke doctors? Do you know, or is that not in your...
As not a provider, I won't be able to give that intel. In terms of that, but like I say, in terms of the modelling, because there is a national model on the rehabilitation element which we are focusing on, there is an opportunity to benchmark about expected staffing for the need in Derbyshire, and any reports that we produce will be transparent if there's any gaps and where we need to focus our time and energy.
Thank you. I think it would be useful once this report is put together to invite you back to give us an update on that, please. I appreciate there might not be a definite timeline on that at the moment, but if you could ensure that you, if we haven't already invited you, invite yourselves, because we will want to hear back on an update on what the progress of that stroke report is. Thank you. Any other questions, or can we move on to our final item? Thank you very much for your time. Our final item this evening, I believe, my agenda in front of me, which appears to have disappeared, is our Health Watch, I believe. Yes. That was a good guess. And that is our item 7. So who is presenting that this evening?
There isn't anyone here from Health Watch to present. I believe all the information, though, is there in the report that has been circulated with the agenda pack.
Does anybody have any specific questions that from the report that we want to ask, or are we happy to just accept that report at this time?
Chair, we'll accept the report, but I think, Anley, we do want somebody from Health Watch attending these scrutiny boards, because obviously we don't ask them to come and present a report, but Anley, when they do, we need them here at least just to ask certain questions or go through the report, or they can highlight certain things over the term, over the years and all that, what's happening and how services are improving, how they see it. So I think it'd be good in future they can be present at that scrutiny board meeting. Thank you.
I'll note that and pick it up as an action outside this meeting.
Fantastic. Thank you very much. I echo that comment, Councillor Khan, and it is helpful to have somebody, because often, as part of this meeting, it's a public broadcast. It gives us a better understanding for people watching externally as to what that is, a brief, and then any questions that we might have individually. Okay, we're on our final item now, the item 8, which is our work programme for the rest of the year. There's been a couple of things that we've noted throughout tonight's meeting to make sure that we get further updates on. I won't commit to the timescales that they will be at this point because unfortunately we won't necessarily have the dates and that comes, but I trust our member services colleague to bring us up to date with those.
Yes, I heard from him sort of around January for an initial kind of draft of the review, and then likewise from the autism item, I've noted the action to write a letter, perhaps from yourself or collectively, to the NHS to express an interest in the trial that's happening in Newcastle.
Okay. So in terms of our work programme, we've got a number of items already in the work programme, I understand. Do we have a full calendar yet of those items?
I believe so. I think there is items for the remaining meetings of the civic year, and then obviously come January we'll be populating the coming civic year after that. So.
Perfect. If there are any items that anybody would like to bring, please let me know.
You know, I think this is our first meeting of general health for this year, isn't it? So,
right.
Yeah. So I think I'll come back on scrutiny board after a couple of years. So I'll be still keen if we anyway can bring GP services on the work program. Yeah. So and see how well they're improving, or have they got better, or
Yeah, thank you. We'll look to see if we can get that in either at the latter part of this year or definitely beginning of I would hope we can get something in the diary this municipal year. Thank you very much, everybody, for your time this evening. Yes, we've done very well even with a fire break. So have a lovely evening, everybody, and thank you very much for your attendance. Thank you.